So I have no disclosure to declare. I don't have to tell this audience the relevance of CAR T cells in the field of hematology. We saw some fantastic lecture today and yesterday on the role of CAR T cells in cancer. We as hematologists, we are aware of the fact that in the future we will always have to be in the field with CAR T cells more and more. But an outbreak in the recent year has been that, surprisingly, those therapies have an enhanced role also in autoimmune diseases. I reported here some of the insights from relevant journals. We had also an important mediatic impact of the fact that those therapies have efficacy in autoimmune disorders. If we go to nationaltrial.gov, this is updated to yesterday, and we look for autoimmune CAR T cells for autoimmune disorders, we have now 91 studies active. Almost all of them are active, recruiting patients. And this is just to say that in the next future, we really will have to learn about these trials and to look how data look like for patients with autoimmune disorders receiving CAR T cells. But what is the main effect of CAR T cells in autoimmune disorder? Why should they work basically well as they work in cancer therapies? We know that in autoimmune disorders, B cells are more than cells that become later plasma cells and produce antibodies, but they are rather orchestrating all the immune response, and they are central in immune dysregulation that is crucial for these autoimmune disorders. We reported in this slide the efficacy of treating CD19 target for CAR T cells. You can see that it's actually expressed by a lot of B cells, from the pro-B cells to the plasmablast. Of course, CD19 is not expressed on plasma cells, but to target those cells, we have other targets like BCMA, as I will show you later. We had, in 2019, so very early, some preclinical data of efficacy of CAR T cells in autoimmune disorders. This is a preclinical model of lupus erythematosus systemicus, in which the author reported an activity in mice treated with CD19 CARs against control. You can see that the survival experiments showed benefit of treatment with CAR T cells in mice compared to no treatment. Moreover, also the biopsies that the author performs revealed that we had an efficacy of the treatment in these mice. I really want to show you that this data was obtained in 2019, and only 2 years later, which is kind of surprising in this field in which preclinical testing generally goes long and it takes more time to be translated into clinical testing, was very rapid. So in 2021, we had the first report of patients treated with CAR T cells. It was published in New England Journal of Medicine. It was, again, lupus erythematosus systemicus patients in which CAR T cells, CD19 CAR T cells, were given. The reports were very interesting. The patient was heavily pretreated with multiple lines of immunosuppressive drugs, and he obtained a complete disease remission. The first report was a very short follow-up, since it was indeed the first patient ever reported to be treated with CAR T cells, and the efficacy rate was surprising. Importantly, in the same year, the same group by the group of Erlangen published the follow-up of the first patient, adding 4 more patients to the reports. Indeed, in Nature Medicine in 2021, the authors published the first 5 patients treated with autoimmune disorder and CAR T cells. I want to highlight that all the patients that were reported, the first one, was patients that failed all the available lines of therapy at the moment they were treated with CAR T cells. And the follow-up, which was very short, 3 months, demonstrated a full disease response in all of these patients. So we were very surprised by those data that indeed reported an incredible activity, at least in the very short follow-up for those patients. Moving forward to these first publications, we had a number of different reports highlighting the activity of targeting B cell and plasma cells in autoimmune disorders. Indeed, you can see that lupus, systemic sclerosis, but also neurological autoimmune disorders were treated with CAR T cells, and all of those reports were indeed published in very high impact journals such as the Lancet or New England Journal of Medicine. But to sum up a little bit the experience that we have with CAR T cells, I really want to address this relevant publication in New England in 2024, published by Fabian Müller, indeed from the Erlangen group, in which they have the major expertise in this field, and they're really moving forward this type of treatment for those patients. These are the first 15 patients treated with CAR T cells. You can see that most of them are patients with lupus. We have 3 patients with inflammatory myositis and 4 patients with systemic sclerosis. In these steps, you can see the summarization of the most relevant findings. Basically, all of the patients at the moment of the report had a full, complete disease remission. You can see here that none of them have immunosuppressive ongoing, so they were heavily pretreated patients that received multiple lines of immunosuppressive drugs, and after CAR T cells, none of them was under immune suppression. They were all glucocorticoid-free state at the moment of the report. Moreover, I really want to focus on the reported toxicity of these patients. You can see that basically all of them experienced CRS, but only G1. Only one patient had a CRS G2. Only one patient had ICANS, G1 ICANS, and none of them experienced bone marrow toxicity. This is highlighting a low rate of toxicities in this patient compared to patients with lymphoma or lymphoblastic leukemia that have higher rates of toxicities. Of course, we're dealing only with the first 15 patients, so we really need more robust data to show that the toxicity is lower, but in the first report, we indeed had very low rates of CRS and ICANS. Systemic sclerosis, as you may know, is a relevant disease in which also autologous stem cell transplantation has been reported to be efficacious. I will show you a little bit the data in the next slide. But in the severe forms, it accounts for a high proportion of patients with mortality and morbidity in autoimmune disorder. The 5-year mortality of the severe systemic sclerosis is 30%, so it really represents an urgent unmet clinical need. And in this disease setting, similarly to the lupus patient, the authors report an activity of CAR T cells. This is the first cohort of treated patients. We have 6 patients. You can see then 2 of them had cardiovascular and pulmonary involvement, and all of them had an important involvement of the skin. This is reported by the MRSS score, which is very high in those patients. And these are the results. You can see that the EUSTAR activity index was low after CAR T cells in all of the treated patients, similar to the disease index. This is very relevant indeed for us monitoring of that disease. Moreover, the improvement was also present in the skin, which is a relevant component, as I was mentioning in this setting. And the digital ulcers and the Raynaud phenomenon was lowered after CAR T cell infusion. Interestingly, the autoantibodies that are not pathological but are bona fide some markers of this disease decreased after the CAR T cell infusion, even though in 2 patients started to go up again sometimes after the infusion. So we know that these autoantibodies are not driving the relapse, but of course they can testify some disease activity. So this is to point out that it's really relevant to look at those patients in the long-term follow-up and see how CAR T cells indeed may be able to control disease. Moving beyond some experience, these are from the group of Kroger in Germany, of CAR T cells also in neurological autoimmune disorder have been reported. The 2 first patients were published last year in Med. no ICANS and no CRS, thus suggesting that also the presence of autoimmune disorder within central nervous system is not driving the ICANS. This is something very relevant. The patients that were treated were patients with progressive MS. We know from the transplant experience that these are the most difficult patients to treat, since they have indeed a progressive disease, and also autologous stem cell transplantation. It's very difficult to achieve results in this setting. But the relevant findings here is that CAR T cells did expand in the blood. They were present within the CSF, at least in one of the two patients, and they accounted for the vast majority of circulating lymphocytes within blood, but also in the CSF. The authors reported an activity, a target activity of CAR T cells, since you can see here that oligoclonal bands were reduced within CSF in the treated patient. We have to say that the follow-up is very short, and one of the two patients experienced a new lesion after CAR T cells. This highlights that maybe in this disease setting, CAR T may not be such as efficacious as in the other autoimmune disorders, but the patient selection and of course also the disease selection is very crucial. We really want to see how they act in the field of relapsing remitting MS. But what's happening in the peripheral tissue in patients treated with CAR T cells? I really think that this slide summarizes very well what is the difference among CAR T cells treatment and conventional monoclonal antibody treatment. These are biopsies taken from patients before CAR T cell infusion, after CAR T cell infusion, and after treatment with rituximab, which is a monoclonal antibody that we know very well. You can see that after CAR T cell infusion in the lymph nodes, CAR T cells are able to completely erase the CD19, so the B cell compartment, and this is not happening with rituximab therapy. I really think that this is very informative also for other CAR T cells conditions such as tumors. You can see that CAR T are really able to go in periphery, and they're really able to eliminate B cells more profoundly than what monoclonal antibody can do. This was published last week in Annals Rheumatology Disease, and it's really motivating the efficacy of CAR T cells, I think, in the field of autoimmune disorders. Moreover, again, in April 2024, the authors described a new toxicity, so a new toxicity beyond CRS and beyond ICANS, which is named LICATS, Local Immune Effector Cell-Associated Toxicity Syndrome, in CAR T cell treated patients with autoimmune disorders. So it's very specific of patients that receive CAR T cells. The authors report 4 different grades. This was published in April in Lancet Rheumatology. And what they describe is that it's a toxicity mediated to what we saw before, so the local penetration peripheral tissues of lymphocytes of CAR T cells. It generally presents very early, so in the first 20 days. It's associated with inflammation, and it's very peculiar. You can see down on the left side of the slide that different diseases have different forms of LICATS, potentially explaining the involvement of autoimmunity, for instance, in inflammatory myositis, in which muscles are really the point of the inflammation. We can see that LICATS involves generally muscles. You can see how skin is also very often involvement, and the treatment is generally steroid. The authors performed a biopsy of the skins, and they showed that no major infiltration of immune cells were present, thus suggesting that this phenomena is more mediated by inflammation, by vasoreactivity, more than tissue penetration, suggesting that these complications may be a mild complications that could often be seen after CAR T cell infusion in autoimmune disorder patients. Moreover, I also wanted to report this data that I think they are interesting. We had the first report of relapse after CAR T cells in autoimmune disorder patient. This was a 45-year-old woman patient treated with CD19 CAR T cells with inflammatory myositis. The patient received CD19 CAR T cells, and you can see here in the B panel that the score after the first infusion in blue got better. So the patient had an efficacy of the first infusion of CAR T cell treatment with CD19, and then the patient relapsed. After relapse, the investigators decided to treat for a second treatment with CD19 CAR T cells, and surprisingly, no benefit was observed. You can see here that in the B panel, the muscle score after the second infusion in violet, no efficacy was present. So the authors decided to investigate what was happening in this patient, and they were able to isolate some CD19, anti-CD19 CAR T antibodies. I think this is really important. So these are patients that have autoimmunity, that have tendency to develop antibodies, and this is one of the first reports of patients that develop antibody anti-CD19 CAR T cells, that they are also probably involved in the fact that these CAR T cells are not able to expand. So the first time the patient had the expansion of CAR T cells, but the second infusion was not associated with expansion. This is testifying that those antibodies could be relevant in this field, and of course should be studied also in cancer patients. So the authors decided to have a short course of daratumumab and then change CAR T cell target. They used BCMA CAR T cells, so the third CAR T cell infusion for this patient, and surprisingly, you can see here that the muscle score got better again. So changing target in this complex field got an amelioration of the disease. This is, I think, very relevant also for understanding the biology that is behind the CAR T cell activity. Moreover, in autoimmune disorder, the field is rapidly moving. We have some reports of allogeneic CAR T cells. Of course, the role of CAR T cells is different. We need some immunomodulation more than target. So probably more than in cancer, we can have we can tolerate less survival, less benefit. And these reports published in Cell last year, reports on the allogeneic CAR T cells for 3 patients, 2 with systemic sclerosis, 1 with immune-mediated necrotizing myositis. The authors had a complex gene engineer to avoid GVHD, and again, some clinical success was reported. There is also space in autoimmune disorder for bispecific antibodies. The competition with CAR T cells, it's very similar to the one we're looking at in lymphoma and leukemia. We don't have time to go through this, but of course, by mediating B-cell depletion, they could be very, very effective also for autoimmune disorder, just similar to CAR T cells. And moving beyond, we have some preclinical experience also with CAR T regulatory cells. So we are engineering CAR T cells, regulatory T cells, in order to recognize the autoimmunity sites, the specific autoimmunity niche, expand, and have some immunotolerance activity against autoimmune disorders. This work is very nice work published in 2044 in Nature Communication by Matteo Doglio, and it really shows how in a preclinical model, CAR T regulatory can give an immunosuppressive state in order to counteract autoimmunity in this disorder. It's a lupus model. For this, we have now some guidelines that have been recently published, led by Dr. Raffaella Greco, from which we are positioning CAR T cells in autoimmune disorder in the field, since we have a lot of experience that is now ongoing. And we are launching also with the EBMT a survey in order to assess the real-world data of CAR T in autoimmune disorder. If you're interested, please contact me. I am one of the investigators in this study, and we're launching the survey in these days, so we are exploring how the field is moving. So just to sum up this first part, CAR T cells showed incredible benefit in the field of cancer. We are now seeing that they are able also to counteract autoimmunity. We have a lot of conditions. We really want to point out how the efficacy of this treatment would be in the long term. We have a lot of challenges. Of course, we have to assess if they work, if the disease activity is sustaining during time. And of course, we really want to look at toxicity more in detail and in longer follow-up. The elephant in the room here is second malignancies. Of course, we're dealing with patients without cancer. We're dealing with patients with autoimmune disorders. So we really want to look well at the data of second malignancy. And for this, we need time to assess the efficacy of those treatments. The final part of the presentation is regarding the other cellular therapies that we've been knowing in the field since now 25 years or 13 years, which is autologous and transplantation in autoimmune disorders. You can see that the trend in Europe has grown up for at least until the pandemic. Then we had a stop due to the pandemic, but we are aware that numbers are still growing. You know that transplantation, the main indication are for multiple sclerosis and systemic sclerosis, which are the main indication in which we showed some activity in these diseases. These are the main indications, so we are aware that transplantation is an active therapy for autoimmune disorders with a lot of benefit reported. I really want to mention that we have indeed a lot of works and a long follow-up of this patient. These are some works that highlights the therapeutic implication of transplant. I want to report the presentation by Kirill Girzov at the 51 annual meeting of the EBMT in Florence. He was presented at the Presidential Symposium the reports of the larger cohort of patients with autoimmune disorder, more than 500 patients with 90 months, so a very long follow-up for this condition, highlighting that we have very long-term follow-up data in different CAR T cells. And just to conclude, I want to briefly report one of the experience we have with transplantation and rare neurological diseases in our hospital. We have the two cases of patients with neuromyelitis optica. Neuromyelitis optica is a rare neurological condition different from multiple sclerosis, which generally presents with optic neuritis and other neurological symptoms. It's a very progressive disease with few treatments available, and very importantly, it has a pneumonic but also pathological autoantibodies, which is anti-aquaporin 4 antibody. We had two patients that were treated in our center 15 and 16 years ago, so really long follow-up. There were two patients with very aggressive disease. The first one, a short course of disease. The second one, the longer one. They were positive with autoantibodies. And the both of two already underwent autologous stem cell transplantation. So we really did not have any other option for those patients. So we decided bravely, because it was one of the first reports, to treat them with CAR T cells, with allogeneic stem cell transplantation. And we indeed treated them with transplantation. The two patients, okay, yeah, I'll be brief for the final part. So we treat them with transplant. We had a matched related donor and an unrelated donor from the registry from the second patient, and we used peripheral blood stem cells. This is the course of the two patients. You can see that the first one is now stably without new lesion after 16 years after transplantation. You can see the MRI images, which are completely negative for new lesions. The second patient had a similar course of disease, so really high efficacy treatment in a very hard to treat disease setting. We studied the immune reconstitution. We saw that the patient had a normal immune reconstitution in the long-term follow-up after treatment, and we were able to document an expansion of T regulatory cells. So really, we want to point out whether these T regulatory cells are the one that mediates the benefit of the long-term follow-up of the patient treated with stem cell transplantation for rare autoimmune disorders. Now the patients are well. They are indeed 16 and 15 years after follow-up. They have full donor chimerism. One of the two patients also became father of children, and the EDSS lower from 8. He was to wheelchair to 2. Is now able to walk and have a normal life. Similar happened also to the second patient. Just to conclude, this is a summarization of the different effects that we have from CAR T cells and stem cell transplantation. Of course, we have longer follow-up for stem cell transplantation, shorter for CAR T cells. We really know well the toxicity associated with hematopoietic stem cell transplantation. We really want to assess in the long term what happens in patients treated with CAR T cells. As I was mentioning, they seem to be very effective. We really want to look better at toxicity rates, in particular at second malignancy. And for this, the registry and other entities are very important, and they play a key role in the study, in post-authorization studies. So I really want to thank all the team in San Raffaele, especially my mentors, and of course the EBMT for giving me the possibility to be here today, and you for the attention. I will be glad to take the question if you have it.